Thank you for setting that recording. We will be recording our meeting today, just to let folks know. And we will dive right in. Also today we're joined by Erin Green, the Health Disparities and Equity, Diversity and Inclusion Officer at HCPF, and the CHI team, Kimberly Fu, Ashley Brown, and Emily Leung as well. And we're going to move on to our next slide. So here's our agenda for today. We're going to be reviewing just a welcome and overview of the health equity plan, some value-based payment models in health equity, data management and the role of that in role of providers in advancing the health equity, and then community engagement opportunities, next steps, and a Q&A, an opportunity for Q&A. So there are a few ways to participate today. You're welcome to share your questions in the chat. We'll be monitoring the chat as we go for Aaron, but he does ask that you just hold your question. We'll hold the questions until the end. So if you put it in the chat, we will get to it later. And then if you would like to also verbally ask your question, you're welcome to raise your hand at the end of the presentation. And of course, this meeting will be posted on the APM 1 website as it's being recorded as well. And then finally, the written feedback. We love written feedback. So please, at any point in time, if you didn't get a chance to ask your questions or you thought of it later on, we would love to hear from you. So please email the Colorado Health Institute at focusgroups@coloradohealthinstitute.org no later than Wednesday, October 25th. And I'm going to pass it off to Aaron.
Thank you, Mariah, Zoe, Kimberly. A huge part of increasing quality indicators is tying in equity, access, and that is done by actively addressing health disparities. Good morning, everyone. My name is Aaron Green. My pronouns are he, him, his, and I have the honor and privilege to serve as the department's Health Disparities, Equity, Diversity, and Inclusion Officer. And for the participants on the call or watching the future recording who are blind or low vision, I will provide a visual description of myself. I am an African-American cisgender male in my mid-30s. I have mahogany brown skin, short brown hair. I am wearing black rimmed glasses with clear lenses. I have facial hair. I am wearing a blue blazer with a cream sweater underneath and a gold lapel flower. I'm in my home office and I'm very excited and honored to be here with you all today. I have been with the department for 2 years. I will do a master's degrees in social work and management with over 20 years of working with marginalized communities and a certificate in equity, diversity, and inclusion. I would also like to acknowledge Nicole Nyberg, our department's quality performance unit supervisor, for her assistance and partnership in this work as well. The quality section is responsible for developing and implementing quality strategies, performance measurement and management, and other quality improvement activities alongside my program, the Health Disparities in Equity, Diversity, Accessibility, and Inclusion program. We work in tandem to ensure quality care for all of our members. Next slide, please. So equity is embedded in everything that we do, and it starts with our mission to improve healthcare equity, access, and outcomes for the people we serve while saving Coloradans money on healthcare and driving value for Colorado. Next slide, please. Why do we recognize the land? To recognize the land is an expression of gratitude and appreciation to those whose territory we reside on. It's a way of honoring the indigenous people who have been living and working on the land from immemorial. It is important to understand the long-standing history that has brought all of us to reside on this land and to seek to understand our place within that history. Land acknowledgements do not exist in a past tense or historical context. Colonialism is a current, ongoing process, and we need to build our mindfulness of our present participation. It is also worth noting that acknowledging the land is indigenous protocol. We would like to acknowledge that what is now Colorado includes the lands of the Ute, Arapaho, Cheyenne, Dene, Lakota, Apache, Puebloan nations, and many tribes, and that the sovereign tribal governments of the Ute, Mountain Ute, and the Southern Ute Indian tribes still reside in this state. These tribes are the original stewards of these natural areas. We want to take a moment to honor and respect these original stewards of the environment and their relationship with the land. Next slide, please. So in the next couple of slides, I'm going to highlight at a very high level how health equity is a top priority for our department. Over the last 3 years, we have worked collectively with leadership, departments, regional accountable entities, members, and other stakeholders. And this presentation will highlight some of those initiatives, as well as how equity is at the forefront of how we are delivering care to our members. Some highlights will include the creation of our internal health equity dashboard. Nicole Nyberg will go over data management and provide high-level screenshots of the capabilities of how we are leveraging data. We also developed our health equity specification documents as a guideline for how the RAIs can set targets to focus on specific core measures, which we will go over in the next few slides. The most recent data files have been shared with our RAIs and child health plans and will continue to be updated quarterly. We have required all RAI, MCO, and CHIP plans to have health equity plans, and their first versions will be submitted to my office by December 31st of 2023. In future slides, I will go over more in depth the successful launch and implementation of our statewide health equity task force, stakeholder engagement, and how we plan to continue to explore and improve alignment in our policy goals and incentive metrics. Next slide, please. As mentioned in our previous slide, we have applied a health equity lens across the programs and initiatives in our department. We piloted the health equity framework and spread it throughout HCPF and launched a statewide health equity task force. To date, we have held almost 20 health equity public town hall meetings, 18 to be exact, with community feedback and stakeholder engagement, and we are on track to hold 20 meetings by December of 2023 with over 2,500 attendees. And I'm sure many of you on this call have been participating in those efforts. We've also focused on increasing vaccination rates among members. We conducted data analysis, partnered with regional accountable entities. We've implemented communications. We've provided provider incentives to vaccinate, engage communities, and partner with the Department of Public Health and Environment. We published the second Health First Colorado Maternity Report that examined maternal health during the COVID-19 pandemic, which provided a window into the lived experience of members and laid out HCPF's roadmap to improve maternal health care and equity. This report focused on equity and outcomes and was featured in a maternity report webinar and was informed by our Maternity Advisory Committee, also referred to as the MAC, composed of Health First Colorado members with lived experiences of maternity care. We continue to invest, strengthen, and transform behavioral health care, often through our collaboration with the Behavioral Health Administration, also referred to as the BHA. Investing in the behavioral health safety net, improving behavioral health access by adding 2,220 behavioral health providers, which is an increase of 25% over the past 2 years to our network from April 2021 to March 2023. The integration of behavioral health into primary care by increasing adult beds and youth residential beds, adding a tribal substance use disorder facility, increasing high-intensity outpatient and transition services statewide, enhancing mobile crisis delivery, and connecting 350 people to permanent supportive housing with on-site social and clinical supports. There is still work to be done, and it will take all of us to strengthen our commitment for equity, diversity, inclusion, and accessibility. Looking ahead, we continue to make progress on our health equity plan. We have goals to continue to identify disparity and differences among our data. We will continue to identify key populations that are actionable strategies to close the gaps. This is why we look forward to the health equity plans that our RAIs will submit by the end of December. We will continue to be closely responsive and center member experience, as well as making sure as we roll out ACC Phase 3.0 that equity continues to be at the center point of all things that we do. Next slide, please. So this slide represents a visual snapshot of the health equity initiatives that I just reported on earlier, and we will touch upon a few key updates as an overall overview. But I wanted to make this slide very clear that health equity must be woven into every facet of our work at the Department of Healthcare Policy and Financing. A huge part of improving quality is addressing the needs of all Coloradans, which, as I had said before, is a department priority. The way we address these needs is by identifying and addressing health disparities through value-based payments, better tracking of our data analytics and insights, as well as stakeholder engagement with the targeted focus on vaccinations, prevention, maternity, perinatal health, and behavioral health. Colorado has been instrumental in a variety of health equity initiatives, and throughout this presentation, I will highlight more in depth. It's so important to know that our health equity plan is comprehensive and culturally responsive and has been in implementation since July 1st of 2022. We've added health equity into our contracts, which I shared before, and we will continue to stratify our data. By partnering with our regional accountable entities, which is a core vehicle for delivering and managing member care for Health First Colorado, or Colorado's Medicaid program, the ACC, or the Accountable Care Collaborative, balances the efficiency of a single statewide program with the agility to meet the unique needs of Colorado's diverse regions. It is fundamental, and this is our premise, that our regional organizations are in the best position to deliver the programs in response to the unique geographic community differences across the state. And so for this reason, the ACC does not use one central administrative organization, but instead has managed care entities called regional accountable entities that manage care in each of the 7 regions of our state. Next slide, please. So now I'll be talking about value-based incentives. It's really important that we're paying for quality, not quantity. And this is our methodology to reduce health disparities. And as I had shared before, we will be in alignment with ACC Phase 3.0 priorities. The department is committed to paying providers for improving quality while reducing identified health disparities. As the department redesigns the delivery system for 2025, quality initiatives have been reviewed and updated to ensure inclusion of expectations for regional entities to close health disparity gaps between the highest and lowest populations they identify on priority measures over the course of the 7-year contract period. The department is exploring options for incentivizing disparity gap closures in the future. As leaders in this work, as providers, we have found the formula that links quality and equity. Quality outcomes and healthcare are inherently intertwined with equity. Next slide, please. The two concepts are interdependent because without equity, there can be no assurance that healthcare outcomes are truly quality. We have done this with the intentional methodology of quality measure alignment, which includes identifying chronic conditions or chronic diseases which require ongoing medical attention or limit activities of daily living, or both, as you all know, for a prolonged period of time, such as cancer or diabetes. Colorado has leveraged payment reform. Traditional fee-for-service payment models reward volume over health outcomes for quality performance. So we are focusing on alternative payment models referred to as APMs, which is incentive care providers to control costs while ensuring good patient health outcomes. Colorado intends to have half of all Medicaid payments tied to these value-based arrangements by 2025. Our RAIs, or regional accountable entities, are critical to the success of APMs. They are responsible for supporting providers and participating in APMs and meeting quality improvement goals. APM indicators are intentionally aligned with the RAI quality performance indicators and other identified national measure sets to reduce provider burden and ensure all entities work together to improve the health of our members. Key examples include making care primary, a Medicare payment reform initiative to align Medicaid payment strategies to performance. APM 1, an enhanced rate to providers and adjust payments based on performance. We'll also talk about very briefly APM 2, which allows for increased investment care improvement and eligibility to share in the savings that result from improved chronic care management by meeting episode cost reduction targets. To date, more than 95% of clinics are meeting the quality threshold set by APM 1. High-performing clinics are encouraged to consider the voluntary APM 2 program that builds on the foundational values of APM 1. In addition, our maternity bundle payment model is HCPF's first episode-based payment program, which aims to raise the quality and lower the cost of maternal care while advancing maternal health equity. It covers all prenatal, labor and delivery, and postpartum care for pregnant and birthing members. Another payment model that is undergoing significant transformation is our behavioral health APM. HCPF is working with stakeholders to reform how behavioral health safety net services are funded. The goal is to move away from fee-for-service reimbursement and emphasize value over volume of services by rewarding safety net providers for care coordination and quality outcomes. Metric framework development, which is evidence-based, development of shared decision-making across the agency is fundamental. As well as federal compliance, we abide by CMS core measurement framework, as our Chief Medical Officer, Dr. Pete Walsh, who is my boss, has made it very clear that we continue to move forward by alignment of our quality outcomes by way of core measures. And finally, a statewide cross-region program and metric alignment that is stratified by important demographic variables. This brings us to how our vision of equity and statute compliance has elevated our ability to take significant steps to address health disparities by way of Senate Bill 21-181. Next slide, please. So it is important to the department to align measures in our health equity plan within specific focus areas for our first iteration that was published back in June of 2022. Most of the indicators that you see on this slide align with Medicaid required measures in the CMS adult child core sets. It is important to note that some of these identified measures are specific to adults. So 4 of these measures are excluded from Colorado's CHIP Plus programs and our health equity plan focus expectations and reporting requirements. As you all are aware, the Center for Medicare and Medicaid Services, CMS, contracts with NCQA to collect healthcare effectiveness data and information set, also known as HEDIS. The HEDIS measures relate to many significant public health issues such as cancer, heart disease, behavioral health, and diabetes. A good number of the CMS core measures in both the adult and child sets are defined by HEDIS measures, and this is a key strategy for our health equity footprint. Colorado uses CMS core and HEDIS performance data to identify opportunities for improvement, monitor the success of quality improvement initiatives, track improvement, and provide a set of measurement standards that allow comparison with other plans. CMS core and HEDIS data help to identify performance gaps and establish realistic targets for improvement, which is pivotal in how we are addressing and making sure that our RAIs understand their responsibility to reduce health disparities among our members. Next, Nicole Nyberg will go over data management, focusing on 12, well now 17 core measure sets, and how the health equity dashboard has been integrated into our internal processes. And then I will follow up with the role of providers in advancing health equity. Turning it over to Nicole.
Thanks, Aaron. Hi, everybody. I'm Nicole Nyberg. I am the Quality Performance Unit Supervisor at the department. Apologies for not being on camera. I am having some internet issues. So to prevent freezing, I'm going to stay off of camera while I run through these slides. Next slide, please. So an internal health equity dashboard was developed by the department's data section. We're reviewing it internally on a quarterly basis. And then from there, we're making updates to demographic measure files that we're sharing with the raise on a quarterly basis. The point of the dashboard was to help provide the most updated disparity data that we had access to. And really embed a health equity lens in the metric deliverables. The data in the dashboard stratifies our measures by all available population identifiers and compares it to national benchmarks, department goals, and statewide measures data. The dashboard itself does stratify data by race and ethnicity, gender, some geography filters, disability, and other identifiers. If we can go to the next slide, please. So the exception of 3 measures, all the rest of the measures are run through a certified HEDIS reporting tool called Care Analyzer that the department uses. The data is then matched with patient demographic data and shared with the RAIS on a quarterly basis. What you see on the following screenshots is going to reflect performance in calendar year 2022. All rates shown are going to remove any categories with a denominator under 30. And right now we can only use this dashboard internally. We are working on having the capability of sharing this publicly and with the raise so that it can be used outside of live meetings. Next slide, please. So the raise are, like I said, getting a quarterly file, and they're using these files to identify their priority populations in their health equity plan within each of the measures based on the demographic fields available to them. The raise are then using the data to build and implement appropriate interventions for the targeted populations. So what you see on the screen is a couple of the data filters that are available right now in the data that we share with the raise and on the dashboard. The dashboard also will highlight the overall performance of each ray, the statewide performance, the NCQA HEDIS mean, and in the future, we're looking to build in additional filters such as location. Currently, the 3 measures in the yellow box on the screen here are not on the dashboard. Just data availability prevents them from being on the dashboard right now, but they will be in the future. Next slide, please. So here you can see just a sample of one region. I'm just gonna run across the layout really quick and then we'll look a little further, but in the upper left-hand corner, we can select which region we want to focus on. The second box to the right allows us to select what filter we want to look at. One more box to the right allows us to look at a specific time period. So this says January 1, 2022. That is the first day of the 12-month reporting period we're looking at. Down below in the bar chart on the left column, you can see the measure names are listed, and then every category that has a denominator of 30 or more will be in each of the bars. The vertical lines, the black vertical line represents the statewide performance. The green vertical line represents the ray performance. And then the orange vertical dotted line represents the NCQA HEDIS mean. So this way we can look at each population compared to the overall ray performance, compared to the statewide performance, and the HEDIS mean all at one time. So this is a view of our race and ethnicity filter. If we can click to the next slide, please. So another important thing that we wanted to make sure we could look at was member language. So on this slide, you can see that in this one measure, the ray that we're looking at has about 20 languages just related to child and adolescent well care visits. that they need to be aware of when they're looking at building out interventions. Next slide, please. So this is another view within our dashboard that allows us to apply more than one filter at a time. So the upper screenshot, the left box has trending data that looks at Colorado performance, HCPF goal, and the NCQA HEDIS mean just at a very high level. The vertical bars, that's where the two filters will play in. So in the first example, we have them filtered by region. So the members Ray is the first filter. The second filter here is the member's disability status. The width of the blue bars corresponds with the size of the population in that specific filter. So if it's a bigger bar, there are more people. If it's a smaller bar, there are less people in the denominator. There's an orange bar that also allows us to continuously compare against the department goal, which is a lot of times based on the 90th percentile HEDIS benchmarks. The second screenshot on this screen, it's the same format. The second filter we selected here is member gender, just so that we could show the different views. Next slide, please. So a couple of other filters that we thought were important to be able to look at was the PCMP provider type. So this first screenshot shows clinicians that are not FQHCs. FQHCs, we can see rural health centers separated, and a couple of other things just so that we can see what, if there's any correspondence with the type of practice a patient is in. The second filter shows member age as the second filter. So each region is broken out, and then the age groups that we're looking at here, we break apart the child age groups. This wasn't the best measure to choose to show the child age groups, but we do have those broken out in the same breakouts as EPSDT. And then after 30 and up, we have it broken out into 10-year intervals. So that way we can look at different parts of life and how that could be affecting measure performance. So that is my last example. I will hand it back to Erin to talk about the role of providers in advancing health equity.
Great. Thank you so much, Nicole. Again, thank you to our DAS team and our quality team. We're so excited to have this dashboard live. We will be doing live demonstrations during our meetings. So we'll be sure to share that information with you all so we can take a deeper dive and actually do a demo of the dashboard. So again, I will now focus in on your role as healthcare providers is integral in advancing health equity. It's very clear that, and our perspective is that health equity is both an outcome and a process. That health equity happens when everyone has equal opportunity to be as healthy as they can be. So no one's race, ethnicity, disability, age, sexual orientation, gender identity, socioeconomic status, geography, or preferred language should negatively affect their health care. Health equity work includes removing obstacles to healthcare access and positive health outcomes. By supporting access to healthcare, which means everyone gets the medical services they need without barriers like cost, location, or discrimination, it's a human right, period. Primary care providers also play a critical role in supporting preventative care for patients. You all stabilize long-term relationships, gaining a deep understanding of patients' health history and risk factors. This familiarity enables personalized preventative strategies, including vaccinations, screenings, lifestyle counseling, and early intervention for chronic conditions. These healthcare professionals, such as yourself as providers, educate patients on healthy living, emphasizing the importance of regular checkups, screenings, as I said before, and risk assessments. By promoting preventative care, you all as primary care providers empower patients to proactively manage their health and reduce the burden of illness, ultimately improving overall well-being and reducing healthcare costs. This is health equity. Looking at cultural competency, responsiveness, and humility, this is vital within the healthcare system. You all improve and evolve by understanding diverse patient backgrounds, beliefs, and values. As providers, you must adapt your care to be inclusive and respectful, addressing cultural differences and sensitivity. Humility encourages learning from patients and recognizing your own biases, and this will foster trust. This approach enhances patient-provider communication, improves health outcomes, and reduces disparities, which will ensure that every individual, regardless of their cultural background, receives equitable and effective healthcare. As highlighted, screening and early detection by primary care providers are essential. You all catch health issues at their most treatable stages, preventing complications and improving patient outcomes. By regular checkups, these save lives. This is why screenings are a focus on our health equity plan. Moving towards health literacy and education, this is fundamental for our members. Understanding medical information, treatment options, and preventative measures empowers individuals to make informed decisions about their health. It ensures communication with you all as providers, ensuring better care and treatment adherence. Educated members are more likely to engage in preventative practices, manage chronic conditions effectively, and recognize warning signs early, leading to timely interventions. This not only improves individual health, but also reduces the burden on our healthcare systems. In addition, health literacy is a social determinant of health, which impacts disparities in access and outcomes. By promoting health education, we can work towards a more equitable healthcare system where everyone has the knowledge and tools to navigate the complex world of health, ultimately fostering better well-being and lowering healthcare costs. Advocacy for vulnerable populations in healthcare is paramount. It ensures equitable access to quality care for marginalized populations and communities, including low-income, elderly, and minority groups. By addressing their unique needs, advocating for policy changes, and fighting against discrimination, we all can bridge healthcare disparities and promote social justice. This advocacy is essential for creating a fair and inclusive healthcare system that prioritizes the most vulnerable among us. And this includes advocating for policy and resources. This will be able to support, fund, and incentivize needed to deliver comprehensive, preventative, and patient-centered care. This focus on primary care strengthens healthcare systems, improves population health, and reduces healthcare costs in the long run. Notice I keep saying reducing healthcare costs. Finally, care coordination, community engagement, data collection, and research. These are best practices in no particular order as the bedrock of improving our healthcare system. The importance of care coordination, community engagement, data collection, and research cannot be overstated. Care coordination is the linchpin that ensures seamless collaboration among our healthcare providers, reducing medical errors, improving our patient experiences, and ultimately leading to better health outcomes. Community engagement is crucial by involving our members, their families, and local organizations in the healthcare decisions. This approach promotes cultural sensitivity care, tailoring services to the needs of our community, and fostering trust between our members and the providers. Data collection and research continues to be pivotal. This drives innovation, it enhances treatment protocols, and leads to the development of new therapies. Continuous data collection not only helps in early disease detection, but also provides the insights needed to address health disparities and allocate resources efficiently. As we work together, providers must have the capacity, the support, and the agency to be a conductor for health equity. In the next slides, I will pivot and we'll transition into our 7 additional health equity priorities. Next slide, please. Next slide. So as you can see on the slide, part of our health equity strategy, working with the governor's office and the Colorado Department of Public Health and Environment, the Office of Health Equity, through Senate Bill 21-181, the state is mandated to create a statewide health equity plan. HCPF has hit the ground running, and with the support of the governor's office and the lieutenant governor's office, we continue to make strides in our first of its kind health equity plan. As we work with Office of Health Equity, we must create and move forward with more concepts to address health disparities. So part of our first iteration of our health equity plan highlights some short-term and long-term strategies. And so over the course of this last fiscal year, we have developed new incentives, new focus areas, new priorities, as you can see on this slide. So I will go more in depth with the changes to the Medicaid application, but before we do that, I will just touch upon very high level the other 6. So our Spanish-speaking Maternity Advisory Council, we seek to improve prenatal and postpartum care for birthing people in Colorado. This concept will help inform our policy for pregnant and birthing people who speak Spanish through the development of a Spanish-speaking Maternity Advisory Committee. We know that almost 11% of the members that we serve speak Spanish as their primary language, and we will make sure that we provide services that will be tailored to their specific needs. The prescriber tool, the goal is to improve and enhance the utilization of this tool in order to increase positive outcomes for our members, to reduce administrative burden for our prescribers, and to improve prescription drug affordability. The prescriber tool is currently accessible through most electronic health records, or known as EHR systems, and is a multifunctional platform that provides patient-specific benefit and cost information to prescribers, which focuses on affordability and improved service to members. We will also improve and support our behavioral health safety net providers and give them the ability to screen social determinants of health information for our members. In partnership with the regional accountable entities known as our RAIs, community mental health centers known as CMHC, soon to be called comprehensive safety net providers, must demonstrate consistent use of validated screening tools for social determinants of health known as SDOH. Following a positive screen, the agency must provide referrals to support resources and, in some cases, immediate access to supports. Improving chronic care management and access to preventative care for Health First Colorado members and CHIP Plus plan members is a priority. The goal is to close racial and ethnic disparities between highest and lowest performing groups for childhood immunizations, dental care, and well child visits by 30%, and to improve diabetes A1C control. The department will look at closing racial and ethnic disparities that exist between the highest and lowest performing groups and require providers to screen for preventative care needs as well as managing chronic conditions. As a contract requirement, our RAIS and CHIP Plus plans are exploring disparities in the regional health equity plans, which are due to December 31st of this year, to showcase current work being done as well as opportunities to develop new innovations to decrease health disparities. And then also to touch upon the equity study for people with disabilities. This is to improve access to long-term services and supports for members in the disability community, continues to be a top priority for the department. This means that individuals receiving HCPF in Colorado are more likely to be white and English speaking than the overall state population and general Medicaid population. It is unclear what is driving the disparity or how to create more equity in HCPF. So this project is aiming towards better understanding who receives HCPF in Colorado and what services they receive, where the gaps are, and the target outreach to ensure HCPF services are provided to all Coloradans who are eligible. And then we have the 2023 Tribal Relations and Health Equity Study. This research will be used to leverage stakeholder interviews to explore Medicaid best practices, challenges, and opportunities to support healthcare access and outcomes for tribal nations and American Indian Alaska Native enrollees. This study will look into specific areas of best practices such as benefits, delivery system, eligibility, care coordination, and other areas that impact access and outcomes for tribal members, with a large focus on exploring how other state Medicaid programs serve this population. In the next slide, I will then address the long-term project changes to Medicaid application. So as part of our increased focus on equity, diversity, inclusion, and accessibility, we have taken a critical look at our Health First Colorado application to identify opportunities to improve how we're collecting data. So we have identified areas where we believe will improve health equity and how we collect data. So these are optional self-identification questions. It will provide the capability to identify and make informed program, policy, and investment decisions and improve access to quality demographic data. Next slide, please. So we are making the proposal to make the following changes around sexual orientation, to add that question, to look at gender, especially to identify our transgender members, to improve how we're collecting race and ethnicity, to recommend a single question and adding additional options for write-in. Language, we recommend additional questions around English knowledge, and then also around housing status. We recommend an application cleanup. We also are going to provide a disclaimer and the purpose, because we intend to use this data to solely better understand how to meet the healthcare needs of our members, which includes the utilization of services, disease burden, and exploring disparities among our groups. Sexual orientation and gender identity, also known as SOGI. This data is protected by HIPAA and will be kept confidential and protected by law. Responses, as I had said on the previous slide, are optional and not required and will not have any impact on eligibility status. As I stated, this is a long-term project, and we will need the partnership with the Colorado Department of Human Services as our shared application impacts SNAP and food assistance programs across the state. So we are hopeful with these optional questions, we can get CMS approval and fully implement by October 2024. It is worth noting the inability to collect upstream data is a significant barrier to quality data. Therefore, it is essential we are able to have these additional self-identified and optional questions included in the application so we can track downstream and upstream disparities. As we look to modify the application, it is essential that we highlight how we're going to be doing so with our partners. Next slide, please. And so with that includes community engagement. So I am really excited to highlight some of the work that we're doing in Colorado around stakeholder engagement, our statewide health equity task force, and public town hall meetings. Next slide, please. So in Colorado, as you all know, we recognize that measuring health equity outcomes is essential for assessing the fairness and effectiveness of healthcare systems and interventions. But we also must tie this into how we are engaging the community. And so I'm really excited to share that part of the accountability of our health equity plan was to ensure that we had created a statewide health disparities work group. And so it transformed into over 60 ambassadors. So we met last fiscal year. So we started collecting interest from across the state. We held 3 specific planning sessions starting in July of 2022. And our goal was to identify up to 25 ambassadors that was representative across the state. And then we launched our first bi-monthly meeting January of 2023, and the group ballooned to 60 or more ambassadors. And so we've broken it up into 5 work groups: access to care, prevention, behavioral health, maternity, and vaccinations. And these are working groups. So we meet for about 2 hours every other month. And the expectation is we go over specific information, especially the CMS equity pillars. And we use that framework to help inform these focus areas. And the goal is for these work groups to come together and provide specific actionable recommendations to our department, which will be due to us by the first quarter of 2024. And then I also highlighted throughout this presentation, town halls. So beginning in 2022, we've launched these public town halls, which had a targeted focus. So we made each town hall with a focus of African-American town halls. We had Asian American Pacific Islander, disability focus, Hispanic, Latino. We also had a town hall specifically in Spanish with English interpretation. We also had a town hall for American Indian, Alaska Native. In November and December of this year, we will be hosting 2 more town halls. One will be for caregivers, and the other will be for the rural community. And these are all virtual. And so since last year, to date, we'll have up to 2,500 stakeholders. And so this is informing our health equity strategy. And the trends will also be highlighted in our 2024 version 2 of our health equity plan. We have a link on the bottom of this slide. So if you're interested to learn more about our health equity strategy, please feel free to visit our website. Next slide, please. And so it's really important to know how are we building equity into payment models. We have a work group starting in the department, and this is our multifaceted approach. We've had a couple of meetings, and we began to really have conversations of how do we ensure that our payment models are leveraging equity. And so we're talking about what does equitable distribution look like? What are our targeted outreach? What are the populations that we are not focusing on, and then also looking at our data. So you were able to get a glimpse of our dashboard. We're continuing to look at that, but also our incentive payments, looking at that data and making sure that everything that we do has an equity lens. We're also looking at risk adjustments that are aligned with our quality metrics. We continue to look at how are we partnering with the community. So as you heard earlier, that we are engaging the community and making specific emphasis on patient-centered care. And part of that data collection that I just talked about in previous slides, looking at the EHRs to ensure that we can make sure that we're collecting the appropriate data, that no one's being left behind. They're looking at the invisible populations that are not being addressed. And part of building equity into our payment models is to always be transparent and accountable, that we are asking questions, that we are being critical of the current system in place, and how can we get better? If we are making strides in specific areas, where are those areas where we can improve upon? And it's really, what is the gap analysis? What is our current state and what is our future state? If we know that we're lacking resources or research or outcomes in specific targeted populations or specific payment models, how can we continue to be innovative? And so our group of folks from finance and from data and from quality across the department are coming together and having these conversations. And it continues to leverage education and training. There's a lot of best practices out there, but because we know that value-based payments is still a relatively new methodology across this nation, we continue to learn and we can course correct throughout the way. But it's really important to also know that we're focusing on patient navigation services. We talked about care coordination, and that we want to make sure that our members are not having to go to different sites to get different things. And because we also know that transportation is a barrier. And so we don't want our members to have to catch 3, 4, 5 buses to make sure that they get one of 6 things done. If we can create one-stop shops, and also care coordination where our members do not have to retell their medical story, their traumas, et cetera, and that they can have a centralized hub of information. And then we also want to make sure that we are flexible. Part of health equity is it's a journey, and there's going to be missteps, there's going to be failure, there's going to be opportunities to do things in a different way, to be innovative. And so by tailoring and tweaking, listening to our providers, to our partners, to our members is so important that we can evaluate where we have been, but also where are we going. So it's really about having that tailored conversation, being open to feedback, and providing grace with each other, because we know that we're still in trying times, that as we unwind from COVID-19, that there is the residuals of still disenfranchised folks in our communities. And we have to recognize and name the harm that's taken place. And as providers specifically, you all play a pivotal role in making sure that you continue to provide the best quality care for all of our members, irregardless of who they are, who they love, where they come from, what language they speak. Next slide, please. And so in closing, before we open it up for questions, I think I want to spend a couple slides going over next steps and where we are in our journey. So next slide, please. All right, so I want to highlight on this slide what we call Health Equity Plan Phase 1. This is where we really continue to make our strategy more sophisticated, more robust, and as I had shared earlier, flexible. So throughout our presentation, we highlighted all of our strategies since 2021, 2022. And so as of June, we have implemented our first of its kind health equity plan, and we formally launched our statewide health equity task force. We talked about, we added vendor contracts, we added health equity to the vendor contracts. And so I'm so excited that each of our RAIs in our CHIP plans will share with the department their strategies, their investments, their ability to look into the different mechanisms of how they can address health disparities. And so we talked about our dashboard and our specification document. So we were able to launch that. So we're really excited. And so as we move forward in 2023-24, we need to continue to explore the differences and the disparities. We've had very transparent conversations with many stakeholders and with our data team around how can we look at the significant statistic differences between groups and populations to really identify disparities. Is it more of a difference, or is there a specific outlier that is identifying true disparities across the state? And so by continuing to move forward, we plan to roll up our sleeves, and we're so excited that equity continues to be part of our ACC Phase 3 footprint. Next slide, please. All right, so Phase 2, we are currently in Phase 2 of our plan. Our first version was to really implement, but now we're in the execution phase where we want to continue to prioritize how we move forward. So part of that is we're going to get the plans from our RAIs, and we're going to start to have quarterly check-ins with each of our plans, or each of our RAIs and our CHIP plans, to really dive deeper into the strategies, to look at the data, to make sure that we are leveraging our internal health equity dashboard to identify opportunities. Nicole did a really good job of outlining how we've stratified by disability, by language, by geography, by race, ethnicity, by age, etc. And so now we're going to really start to analyze the data. And then by June of 2024, our goal is to then provide our second health equity plan, version 2. It'll highlight trends. It will highlight how we plan to move forward, looking at the data between the last 2 years. And then as we had shared, we've added 5 additional health equity measures, which will be tracked starting fiscal year 24-25. And then part of our health equity plan report is going to actually share the task force recommendations. I expect we'll have 10 to 15 recommendations that outline specific strategies around access to care, prevention, maternity, and behavioral health. And then lastly, part of our work is to make sure that our data is validated. So starting in fiscal year 25-26, all of our health equity measures will be validated, so that way we can make sure that we can intentionally make sure that we can analyze, track, monitor, and assess how we're doing and the means in which we can move forward. Next slide, please. All right, so it's so important for us just to overall highlight how are we going to measure success. We'll do that by continuing to be in alignment with the Health Equity Commission, which is by way of the Office of Health Equity from the Department of Public Health and Environment. We will continue to align our data sets with the quality core measures to make sure that we can enhance our ability to report. So we're closing those pipes. We will continue to focus on our focus areas in preventative services and perinatal care, behavioral health, continue to make investments and aligning our immunization strategy, focusing on COVID as well. So we will make sure that we're looking at gap closure methodology. We've had ongoing conversations based on regional and statewide metrics. So we will make sure that next fiscal year that is a focus. We will continue to leverage different initiatives that can measurably reduce disparities. We will continue to have public meetings to share our health equity dashboard where we can actually do live demonstrations so you can see the different capabilities of that. And we also want to make sure that we can put it on our website for public consumption where we can be transparent. So our timeline continues to be year to year. We will provide monthly updates with our subject matter experts. We continue to meet with our RAIs and CHIP plans on a regular basis to get updates, to share information, to be part of their learning journey. And then, as I had shared before, we will continue to publicly report on what we're doing across the state. So we need all of us, all of you, to continue to be the champions in this work. I'm so honored to be part of this conversation with you all. And so right now, I'm happy to entertain any questions that folks might have. And if anyone else from the department is here to help answer any questions, I'm happy you're here as well. So turning it over to you, Mariah.
Thank you, Aaron. Well, to facilitate a more group discussion, I'm going to stop sharing my screen so we can see each other and see and start having some conversation. So again, how you can ask questions or engage is by either putting questions in the chat, or you're welcome to raise your little Zoom hand and we'll call on you and have you ask your question verbally. Is there anyone that would like to start us off? I have a question in the chat. Is there any, Janet Milliman says, is there any ability to bring in EHR data from providers to supplement the Medicaid application demographic data? Thank you for that question.
That is a really great question, Janet. Thank you so much. If there's anyone from our DAS team who wants to answer that, that'd be great. But I would give you some of my thoughts is, we understand that the ability to have quality metrics is paramount. And so any type of way that we can collaborate and make sure that all of our systems are talking to each other. In the meantime, while we try to modify our Medicaid application, that is a strategy that I'm open to, and I know that our data team would be as well. So we're having conversations internally about how we can leverage our data, and one of that has been EHR. So as we continue to move forward with our proposal to adapt and change our Medicaid application, I will be sure to follow up with you all. Nicole, go ahead.
I just wanted to jump in. So the department has made some connections to collect some EHR data. It's pretty limited to clinical data to support the quality measures reporting. I don't think it's off the table. It just hasn't been part of the pilot conversations about how to get those data feeds working correctly, and to make sure that we're receiving the data that they're sending to us. But in the future, I don't think it's off the table. Go ahead, Pete.
Yeah, I'd like to ask a question if it's okay, Ashley, or specifically, I'm Pete Walsh, by the way, I'm the CMO at HCPF. I am curious what type of data the questioner is referencing, because with regard to Medicaid applications themselves, there is some autofilling that goes on by the operations team when those are sent out. Autofill, in other words, things we can fill in and things we can't. And there's specific federal rules about what can and can't be populated in that way. So I am curious, was the question around race, ethnicity, language, things like that, or was it, could you clarify so we can understand what your intent was?
Yeah, thanks, Pete. So the questions about trust, kind of, I know Aaron's nodding, everyone's nodding. Okay, right. So giving personal information to the government can sometimes feel unsafe to certain folks, but giving it to their primary care physician might feel a little more safe. And so all the literature kind of shows that the data coming straight from the primary care provider is going to be probably more accurate and more complete than what goes into a Medicaid application. So, you know, race, ethnicity, language, you might get, you know, mostly filled out, although I do see a lot of I forget the term is used, multi kind of other type. I can't remember the exact term, but there's a lot of like autofill, I think is
Mutually defined.
Mutually defined. Thank you, Sarah. But then for gender orientation, things like that, the SOGI those placeholders, they might be more, you know what I'm getting at. Sorry, I just got off the treadmill. They might feel a little more protective of that information.
Yeah, and I appreciate you clarifying that. We're going to have to take it back. I will tell you, with regard to race, ethnicity, we're able to, you know, we need to clean up our application and make it more user-friendly and clear. And there's some science behind how to make the questions better, which we've done a lot of research on, and we will get there. But for the most part, we get good. We're able to identify what people intend to attribute themselves to race, ethnicity. But you're right, asking questions around gender identity, sexual orientation, all of those things are more sensitive. And we'll just have to think about whether that's an option or not. But thank you for clarifying.
Yes, thank you for that clarification. Elizabeth, you've raised your hand.
Yes. Hi, good morning. Thank you. So this is Elizabeth Freudenthal. I use she, her pronouns from Children's Hospital. It is so incredible to see the extent of the health equity work that HCPF has developed. And so I want to thank the department. I want to thank Aaron, you in particular, for leading all of this work. It's really exciting. I guess I have a broader point that occurs to me. We just responded to a survey for the department about what RAISE can do about avoidable emergency department use. And a lot of avoidable emergency department use is occurring, at least in the children's hospital space, because people are in healthcare deserts. And so the ED is the only place they can go. I mean, this is standard, you all know this, right? But I'm wondering about risk stratification and the role of, you know, holding providers accountable, or even RAISE accountable for things like that are not necessarily in their control. And the way in which some of these programs to improve equity have these unintended consequences of, you know, rewarding practices that already have a lot of resources to support the Medicaid population in these ways. And so to that point, I want to bring up what Colorado Access has done recently, which is they have created, and Janet, I think this is your idea, so maybe I should just have you talk about it. But it's really exciting. So they're taking some of their performance pool funds and distributing them to practices in their region that can't don't meet eligibility levels for engaging in some of their value programs. If I think so, Erin, I see you nodding. Things like that, I think, are pretty exciting ways to kind of use an equity lens to distribute resources. And so that's exciting. And then I guess a question I have then is, are you looking at risk stratification in a way that adequately will support providers to do that long list of things on that slide about the provider role in advancing equity? Like, that's a lot of things to ask a provider to do. And so how are you looking at funding through the APM to support that kind of activity? Thanks.
Thank you for that question, Elizabeth. Erin, would you like to speak to that, or potentially Zoe may have a little bit more to add to it after?
Yeah, I will volley it to Zoe and then I'll follow up.
Sorry, I am doing double duty this morning with my 2-year-olds. If you hear lots of screeching, that is why. I definitely think it's something we can try to include in future APMs. Sorry, Elizabeth, I did think I missed like the beginning part of your question, just because I am trying to entertain a 2-year-old at the same time.
No, the beginning part was just expressing my excitement and gratitude for all this work. Thanks.
Yeah, we are very excited, and hopefully we can incorporate it into an APM more and more in future iterations.
And thank you, Zoe, and shout out to you and being a phenomenal parent. I know we are all multitasking, so thank you for all that you do. And I'll just follow up with, and that's the purpose of our value-based, our building equity into payment models work group. That nothing is off the table, and as we get more sophisticated in how we are looking at APMs, that's definitely something that we will explore. So I'm sure Trevor, Abeda, and others are happy to have that conversation and make sure that that's something that we focus on. So in a nutshell, I would say that more to come on that, but to say that nothing is off the table, I think that there is an opportunity to be as flexible and really leveraging what are our partners doing, what is working well. And that is the footprint of health equity, that there is no specific footprint. There's no blueprint to this. And so what's working well with our providers can subsequently be elevated to a statewide practice where we're sharing information, where we're tearing down silos, where it doesn't matter where you are, what zip code, that you get the same type of quality care. And so part of that is communication. So part of our conversations will most likely to bring that back to this group and others to get more information and input. Because as we move forward and change our efforts and our lens, that we continue to do things that are meaningful and that are grounded in not just evidence-based practice, but practice-based evidence. So I hope that answered your question and your curiosity. And so I think I'll open it up to any other questions that folks might have.
Yes, thank you, Erin. I also quickly wanted to add that CHI is working on the community engagement efforts in a lot of these new APM models. And so this point of view is obviously a wonderful indicator of what we would like to hear in future engagement sessions. And we'll talk a little bit more about that here in a few slides as well, once our questions are done. And Elizabeth, thank you for the comment. So glad to know that we have a chance to think big about this. Smiley face. Does anyone else have any other questions? Well, oh, here we go. Yeah, thank you, Erin. We will also modify our slide to add risk adjustment and risk stratification. Thank you. Would anyone from the HCPF team like to add any thoughts while we potentially wait for folks to type in the chat any questions? Oh, remind us when the recommendations will be released, actually, Janet has asked.
Yeah, great question. So the Health Equity Task Force will vote on their recommendations as a body by the November 2023 meeting. And then they will formally submit those recommendations to the department by January or March of 2024. We'll make sure that our executive director, Kim Bimsteffer, has access to that. Our CMO, Dr. Pete Walsh. We will have a formal response to those recommendations, and then it'll be published in our version 2 by June of 2024. That is a tentative date. Our goal is to, once the governor puts his stamp on the statewide health equity report out by Senate Bill 21-181, once that's published. So hopefully if that is published by March of 2024, we'll move forward with our June date. If it is published later than that, then we will push back our date. So I'll just say sometime in 2024, it'll be made public on our website as well.
Great. Thank you, Erin. Again, opening it up to any more questions. Maybe I'll give us one more minute or two to get any questions in, and then otherwise we can move on to our written feedback on this meeting, on what we would like to hear from you if you can get a chance, or if you had more questions later on.
All right, can I volley a question for folks to ponder?
I love it. Let's do it, Erin.
So if folks want to give feedback now, or in the chat, or in an email, what are you excited most about health equity within your specific practice? What are you doing? What are you seeing? And how can we tap into that? What role can we play to really help accelerate, acknowledge, support, invest? Because as we said before, this is a mutually beneficial continuum where we want to spotlight what you all are doing, but also we want to share what the state is doing. So we're happy to even create a different space to have a more robust report out of all the things that you all are seeing on the ground. But really it's around what's working for you all.
Feel free to raise your Zoom hand if you'd like to answer verbally, or please insert that in the chat. Or if you'd like more time to think on that question, we will have a summary of it. Oh, Elizabeth, though, excited about financial support for providers. We are already doing this work, or who are already doing this artwork, or those who want to but lack capacity. Thank you. No worries.
This is Elizabeth again. I guess no one's talking, so I'll ask. Is the fact that the governor has to essentially authorize a statewide health equity plan, that seems pretty exciting, I think, but I don't know, because so many of these barriers really are at the system level. And so it's a little frustrating to depend on providers to fix it, just as the same thing with education policy, right? Like depending on teachers to fix poverty in a school setting. And so I guess you know, I am pretty excited about a chance to really approach this at a systems level through the governor's office. Is there anything additional that you all can share about that?
Dr. Walsh?
Yeah, I think Aaron has given you the most current update, but I think the way, and again, I don't work in the governor's office and I'm not the executive director, but I would encourage you to read the actual bill, because I think what it conveys is Rick, and I can't get inside of your head about exactly what you're thinking, but I think what it does convey is the concept that this is an all hands on deck challenge. Okay. And so, if you're familiar with what I call the Oregon model, and of course, all things are not perfect in Oregon, but they do have some very interesting approaches. They have a combination of, there is a Medicaid piece of this. And our piece of it is at various levels. There's, rays are part of it, providers are part of it, you're part of it. So there are things within our span of control, okay, that fall directly within our ability. But to solve the broader issues around health-related social needs, social determinants of health, it can't be solved with Medicaid alone. So I think if you look at what the bill's intent is, and I encourage you to read it, you can tell it's around, CDPHE generating a comprehensive report that characterizes the challenges, it going to the governor's office, that each state agency evaluate its meaning and how they can contribute to challenge the problem, and then essentially there being you can look at the language yourself, but essentially each department in the state having I'll say activities related around addressing the need. And so our challenge as a department, frankly, I know we're almost out of time, is we've got a little different problem than most departments in that we aren't just dealing with social determinants of health and health-related social needs. We're flying the airplane at the same time. We're trying to improve those issues. So you'll note our plan is not all about health-related social needs. However, we recognize it as an important component. But I think the whole point of the legislature, just read the intent, read it, is to look at it from a perspective of you could argue about the percentage of the solution of the problem at HCPF, but we're not the whole solution. And I think this whole process that the legislature put in place reflects that. And if you look at the Oregon approach, we had characterized it, you could find an infograph. And again, you can argue about percentages, but they view their Medicaid program as probably 25% of the solution to how big this challenge is. So sorry about the long diatribe, but I would encourage you to read the legislation.
Thank you, Dr. Walsh. I'm going to begin sharing our screen again. Does anyone have any last questions? All right, and Ashley, thank you so much for putting the bill in the chat there for us. There's a link there. Awesome. Well, let's move on to closing out this conversation. I appreciate all the folks that were able to ask some questions, and we can kind of get some good answers as we move into the rest of our Thursday. But again, please, if you didn't get a chance to ask a question, or you wanted to think a little bit more on Aaron's volley to the group, please feel free to reach out via written feedback no later than the 25th of October to either one of us. So Aaron, his email address is aaron.green@Colorado State, or at state.colorado.co.us. And then you can also reach out to me as well at the focus groups at coloradohealthinstitute.org. Again, coming back to the what does all of this mean for future APM programs and future work that we have going on in the state? How are we continually improving and adding work like this, health equity work, into our future programming and hopefully decreasing disparities. If you'd like to find out more, please join our mailing list. There's a link here. There's a link in the chat as well. And you're welcome to use your phone to scan that little QR code. And then, of course, we'll have some more information here in the future as well on how to join some of those conversations and support this work moving forward. We would just like to say thank you, everyone, for your time today and joining us on this early Thursday morning. Please feel free to, again, reach out with any feedback that you all may have. And this recording will be on the APM1 website as well as the presentation. So thank you again.